international conference. We cannot say, but it is on the international level, and we can never reach more than this. And I think I'm privileged today to be among two groups with hematology and neonatology. And I have the privilege to work with both of them at many time in my life. And I do appreciate that although we are always talking about very tiny creature, but we are always giving the talks to stars and very smart masters that they can afford a good knowledge for it. I'm privileged again to be among professors as chairpersons, Professor Nihal Ragal, who is one of the pillars for neonatology, and Professor Safa Shafi, and they know both of them that I always call them the two lines in the field of neonatology, and they are. And again, I'm privileged to be with Professor Tamer Hassan, who is one of the pillars in Zagazig University for the hematology. And now we'll start by maybe I'm not calling her a star, but I'm calling her a sun in the sky of hematology. This is Professor Laila Sharif, and Laila is a sun actually because she is always shining by her talks and by her field, and she will gather together the hematology and neonatology as neonatal anemia. Then will come after several topics, and these are neonatal bleeding, and this will be given by Professor Muhammad Abdel Mohsen, and as was told by Professor Mohsen Alfi, Muhammad Abdel Mohsen is one of the very quiet, active, and very elegant in his knowledge, but he is very modest in his behavior, and I do appreciate that he will talk about the neonatal bleeding. Then comes the talk of neonatal thrombophilia, and this will be given by the second line in neonatology, Professor Rania El Faraj, and ending by the mentor and the master of hematology, Professor Mohsen El Alfi, who will give us anemia beyond the neonatal period. I think by now I have to leave the floor for Professor Laila Sharif to start her presentation. Thank you.
Okay.
After the presentation of Professor Laila, she is trying to join share screen. We will have the
happen. Don't share. I don't know what happened.
We will give you 1 minute to try it, and you cut it from your time. And
when I do to point to screen share screen don't work. I don't know why.
خديجة تقدري تساعدي الأستاذ دكتورة ليلى أو محمد جافي؟
Everything is ready, but I don't
Professor
know.
Laila, if there is any trouble, please just upload it and send it to me by email as soon as possible, and we can share it. We will give 1 minute. If not available, we can shift to the next speaker if Dr. Galila will agree.
Yeah, I think if we have any problem, we can shift to the next speaker. But Professor Laila,
when I just
Yeah.
انا يعني ما بدوس على شير سكرين مش
You can just send it to
Someone
me.
else is sharing the screen now, Khadija. Is anyone
No,
sharing the screen?
no,
Okay.
no.
So you have to share the screen from your own
I don't know
computer.
what happened. So you can start by Professor
You can
Abdel
send
Mohsen.
it
I
by
will
email,
try. I will
Can
try.
we start?
Okay. Yeah. Professor
Can we
Nihal,
start,
go.
Professor Mohsen?
Muhammad.
Okay. Now we have to start, and it's my pleasure to present my dear colleague, Professor Mohammed Abdel Mohsen. He's a professor of pediatrics and pediatric oncology hematology, Children's Hospital Ain Shams University, and he's going to introduce to us the subject of neonatal bleeding. Professor Mohsen, تفضل. Okay.
ايوه السلام عليكم. ازي حضراتكم جميعا. Thanks Professor Galila for the very nice and generous words for me. Actually, I'm so happy to chair in this very important session in the pediatric hematology, neonatal hematology. Thanks Professor, my colleague Professor Nihal. Actually, I'm not a neonatologist, but I'm going to give a focus on the neonatal hematologic problems regarding bleeding, when to suspect and how to treat, and when to refer to a pediatric hematologist.
محمد دوس علشان تبقى فول سكرين، الايكون تحت عشان تبقى فول سكرين، ولو عايز تشير الفيديو نبقى شايفينك براحتك.
اوكي.
تحت البرزنتيشن الايكون بتاع ان هي تبقى فول سكرين. If not is okay, carry on.
Okay.
خلاص go ahead يا محمد.
I'll go briefly through three main items. First of all, I'll speak about the basic physiologic background of normal hemostasis in neonates, followed by the clinical and laboratory approach to neonatal bleeding, and lastly, management of some common bleeding disorders in neonates due to underlying hemostatic defect. For normal hemostasis in newborn, we are in need for 5 main components, including healthy reactive blood vessels, adequate platelet number and function, normally acting coagulation factors, intact fibrinolytic system, and naturally occurring anticoagulants. The blood vessel is formed of endothelium and subendothelial connective tissue or collagen. Both endothelium and subendothelial connective tissues are involved in the process of hemostasis. The endothelial cells have both thrombogenesis and antithrombotic effects. Thrombogenesis through the release of von Willebrand factor, tissue thromboplastin, and the endothelin, while the antithrombotic effect of the vascular endothelium is mediated through expression of thrombomodulin receptors, antiplatelet substances as platelet-derived relaxing factor, prostacyclin, and the release of tissue plasminogen activators, which activate the fibrinolytic system. While the connective tissue or the subendothelial collagen directly bind and activate platelets, release von Willebrand factor, which enhance platelet aggregation and adhesiveness, expression of tissue factor by injured subendothelial connective tissue, which initiates the extrinsic pathway of coagulation. The platelets function. Platelets normally stick to damaged blood vessels, and this function requires von Willebrand factor. followed by spread out to cover the damaged area, platelet adhesiveness via glycoprotein 1b receptors, followed by activation and release of contents from the alpha and dense granules, including ADP, von Willebrand factor, platelet adhesion molecules, B-selectin, integrins, fibronectin, and fibrinogen. Then aggregate together to form what's called platelet plug or primary hemostatic plug, followed by clot retraction to draw wound edges together. The third mechanism is coagulation activation process or fibrin clot formation. Tissue damage exposes blood to tissue factor released from the subendothelial connective tissue. It's called the hemostatic envelope. It initiates coagulation cascade through a series of enzymatic reactions leading to formation of thrombin. This takes place mainly on activated platelets. Thrombin then converts fibrinogen into fibrin, and lastly, fibrin polymerizes and become cross-linked, forming the secondary hemostatic plug by the activated factor 13. The fourth mechanism in hemostasis is fibrinolysis. Fibrinolysis means degradation of the fibrin clot by the enzyme plasmin. The enzyme plasmin is produced from the liver as a coenzyme plasminogen. Plasminogen is activated by the effect of tissue plasminogen activators in response to thrombin spark. This process is necessary to remove clot, and so wound healing can proceed after. The fifth mechanism in neonatal hemostasis is the natural anticoagulants mediated by a number of proteins as antithrombin, protein C, and protein S. And I think this will be discussed by Professor Rania Al-Farash. Deficiency of any of these proteins can lead to increased risk of thrombosis or what's called thrombophilia. This diagram illustrates the interaction and synchronized harmony between the three main elements of coagulation, including coagulation proteins or coagulation factors, fibrinolytic system, and the natural anticoagulants. Tissue factor release in response to tissue injury will activate factor 7 in the presence of ionized calcium. And this complex of activated of factor 7 in the presence of calcium and the platelet phospholipids will activate factor 10. Factor 10 in the presence of activated factor 5 will convert prothrombin into thrombin. This is a very important process. Thrombin itself converts fibrinogen into fibrin, and this action is inhibited by the antithrombin. Thrombin also activates factor 13, activates factor 5, activates factor 8. Not only that, thrombin also combines to the thrombomodulin receptors present at the endothelial surface, causing what's called thrombin-thrombomodulin complex. And this complex activates protein C, and the activated protein C in the presence of protein S will form activated protein C, protein S complex, which inhibits factor 8 and factor 5. At the same time, the thrombin spark will activate tissue plasminogen activators, which will convert plasminogen into plasmin, and the plasmin will cause degradation of the fibrin into fibrin degradation products. Now, what is the difference between neonatal hemostatic system, and is it different between neonatal hemostatic system and the adult or older children system? Yes, it's different. At birth, concentrations of vitamin K dependent factors, that's prothrombin, factor 7, factor 9, and factor 10, as well as factors 11 and factor 12, are reduced to nearly about 50% of the normal adult values. And they are further reduced in preterm infants with increased risks of hemorrhagic disease of the newborn. Also, concentrations of the plasminogen and the natural anticoagulants as antithrombin, protein C, and protein S are low at birth, And as a consequence, both thrombin generation induced by the coagulation system and thrombin inhibition produced by the fibrinolytic system and natural anticoagulants are reduced. This hypofibrinolytic state will compensate for the reduced clotting activity. So there is reduction in both clotting activity and fibrinolytic function. Regarding platelets, platelet count is within the normal adult range in both term and preterm infants, but they are hyporeactive compared with older infants and children. However, thrombocytopenia with count less than 150,000 per microliter occurs in about 25 to up to 40% of sick preterms admitted to neonatal ICU and high with subsequent high-risk bleeding. So neonates are more susceptible to bleeding due to various reasons, including the immaturity of the hemostatic system due to quantitative and or qualitative factor deficiency, maternal diseases and drugs received by the mother that may increase bleeding risk, other comorbidities in the newborn as neonatal sepsis and neonatal asphyxia, exposure to risk birth trauma and iatrogenic insult in the neonatal ICU. All of these factors collectively will increase the risk of bleeding. Despite all of that, the bleeding risk may be reduced. Yes, may be reduced in healthy neonates owing to increased concentrations of some clotting factors as von Willebrand factor and factor 8 with high neonatal backed red cell volume causing more hemoconcentration with concomitant reduction in the fibrinolytic function. So under normal situations, healthy newborns have no increased risk of bleeding compared to older infants and children. What are the underlying hemostatic defects that might lead to neonatal bleeding? These include either coagulation defects, platelet quantitative or qualitative defects, fibrinolytic dysfunction, vascular causes, or combination of two or more of the above factors.
دكتور محمد هنحتاج نجري أكتر شوية.
Okay.
Mohammed, you have 3 minutes للأسف بس.
Okay. I'll go to the clinical approach. 3 main questions have to be answered. Is the bleeding is due to local or systemic defect? Is it hereditary or acquired disorder? Is it due to primary defect regarding platelets or vascular defect, or secondary hemostatic disorder due to coagulation factor defect? Common presentations of bleeding include oozing from the umbilical stump, cephal hematoma, cutaneous bruising, bleeding from the peripheral venipuncture sites, post-circumcision bleeds, intracranial hemorrhage and mucosal hemorrhage as GIT hemorrhage, unexplained anemia and hypotension denoting internal undiagnosed blood loss, and rarely intra-articular hemorrhage and muscle hematomas. Regarding the lab diagnosis, screening tests required for diagnosis of neonatal bleeding include complete blood count, peripheral blood smear, prothrombin time, and activated partial thromboplastin time. If there is thrombocytopenia with prolonged PT and BTT, the diagnosis is probably due to DIC or sepsis. If there is thrombocytopenia with normal bleeding time, normal prothrombin time and activated partial thromboplastin, the diagnosis is usually due to neonatal immune thrombocytopenia, bone marrow hypoplasia, occult infection causing platelet sequestration, or thrombosis. If there is no thrombocytopenia with abnormal coagulation profile, abnormal prothrombin time with normal activated partial thromboplastin time, the diagnosis is mostly early liver disease, vitamin K deficiency, factor 7 deficiency, or warfarin therapy. If there is normal prothrombin time with prolonged BTT, the diagnosis is mostly due to inherited factor 8, factor 9, or factor 11 deficiency, moderate to severe von Willebrand disease. If both are prolonged prothrombin time and partial thromboplastin time, the diagnosis is mostly DIC, advanced liver disease, severe vitamin K deficiency, and deficiency of factors of the common pathway. If the coagulation profile is normal, The diagnosis is mostly factor 13 deficiency, mild von Willebrand disease, platelet function disorders, thrombocythemia, or vascular disorders. Lastly, some neonatal hemostatic disorders are neonatal vitamin K deficiency. It's a fat-soluble vitamin present in many foods. Some are made by the bacteria in the gut. Vitamin K deficiency is common in neonatal period as there is no placental transfer. Deficiency may lead to low levels of clotting factors, causing bleeding tendency in neonates, particularly in preterm infants. Neonatal hemophilia presents usually as post-circumcision bleeds in more than 80% of cases. Hemoarthrosis and muscle hematomas are rare in neonates. Intracranial hemorrhage and cephal hematoma may occur in about 20% of cases in severe factor A deficiency. Family history is absent in 30% of, يعني تلت العيانين, there is no family history of hemophilia. Diagnosed by prolonged activated partial thromboblastin time, normal prothrombin time with low factor 8 levels.
1 minute left.
Okay, fibrinogenemia is a very rare autosomal recessive inherited hemostatic disorders characterized by bleeding occurring in neonatal period, with 85% of cases present as umbilical cord bleeding. It's diagnosed by prolonged prothrombin time, partial thromboblastin time, and thrombin clot time. The diagnosis is confirmed by measuring fibrinogen level, which is markedly reduced. This is umbilical cord bleeding with normal coagulation profile, normal platelet count, normal prothrombin time, normal activated partial thromboblastin time, and normal thrombin clot time. The diagnosis is mostly due to factor 13 deficiency. Factor 13 deficiency is a very rare autosomal recessive hemostatic disorder characterized by excessive bleeding in neonatal period, prolonged umbilical cord bleeding, and CNS bleeds. The diagnosis is confirmed by measuring factor 13 levels. Take-home messages: healthy newborns has no increased risk of bleeding compared with older infants and children, and up to 80% of neonatal bleeding, the diagnosis could be made upon clinical background. Laboratory screening using CBC blood film examination, prothrombin time, and activated partial thromboblastin time is usually required to confirm the diagnosis. Bleeding in healthy newborn is mostly due to coagulation factor defects, whether inherited or acquired, inherited as hemophilia and acquired as vitamin K deficiency. Also occurs due to neonatal thrombocytopenia, whether due to bone marrow failure or neonatal immune thrombocytopenia, or due to thrombocythemia, while bleeding in critically ill neonate is mostly due to DIC septicemia or advanced liver disease. Management of bleeding in newborn is mainly disease specific according to the underlying etiology with proper supportive care. And thank you.
Thank you, Professor Mohammed Abdel Mohsen, for this very informative and very up-to-date presentation. And I hope Professor Laila is ready for us.
Yes.
And before going to Professor Laila, just I want to tell you that the Q&A box, you can share your questions, and we'll, if we have time at the end, we can answer these questions. Thank you.
I guess there will be no time for questions, so we should be, because it's 15 minutes only. Go ahead, Professor Laila.
Okay.
You see now the presentation?
Yes, Professor, you can proceed. Thank you so much. Yes, it's well.
Okay. First, I would like to thank Professor Mohsen MP and the board of Espho for inviting me to share in this wonderful meeting. And thank you so much to the Queen of Pediatric Hematology in Egypt, Professor Galila Mukhtar, for a very nice introduction. And I am very sorry for this interruption. My talk today about the neonatal anemia. This is my agenda. I will start by the hematological.
Dr. Laila, you have 12 minutes, so, and you have 68 slides. So be cautious from the
No,
starting.
no, not all the slide, not all the slide. Professor Mohsen will include it in the presentation. Okay. The lifespan of the RBCs at birth is completely different from the adult. At birth, the lifespan is lower than the adult. We have larger MCV and lower mean corpuscular hemoglobin concentration. There is also high frequency of this morphology in the RBCs. In the neonates, about 14%, and in the newborn, there are at birth many nucleated RBCs and immature RBCs. So what is the definition of neonatal anemia? It is defined as hemoglobin or hematocrit more than 2 standard deviation below the mean for postnatal age, or central hemoglobin less than 13 gram per deciliter, or capillary hemoglobins less than 14.5 gram per deciliters. This is a normal hematological value in the first 2 weeks of life. The hemoglobin at birth is nearly 17 till 2 weeks. The MCV is about 107 and decreased to 96 by 14 days. The reticulocytic count is high at birth, 3 to 7, drop to 1% at 1 week, and also the nucleated RBCs disappear about 3 to 4 days. So what is the pathophysiology of neonatal anemia? It may be physiological or due to blood loss, hemolysis, or decreased production. As we all know, in utero, the oxygen saturation is low, so the erythropoietin production level is high, with the large production of the RBC. You can imagine in the 3rd trimester, the daily productions of the fetal erythropoiesis is 6 times higher than the maximally stimulated erythropoiesis in the adult. Soon after birth, the oxygen saturations go up to about 95%, and this downregulation of the erythropoietin production. This is translated to about 20% decrease in the erythroid progenitor in the bone marrow. In the healthy term, the hemoglobin dropped to about at the 3rd week of life. In the physiological anemia of neonatal period, seldom produce symptom. What happened in the premature? The nadir is lower and reach sooner. The average nadir is about 7 to 9 gram per deciliter at 4 to 8 weeks. And the premature may suffer from poor feeding or weight gain or bradycardia or apnea. The pathophysiology of anemia of premature is multi-complex. It involves physiological factors like decreased erythropoietin, shortened survival of the RBCs, shift of oxygen dissociation curve or rapid growth, or pathological like iatrogenic blood loss, associated comorbidity of the preterm like lung disease or sepsis or nutritional deficiency. The second etiology of neonatal anemia is hemorrhage. It may be antenatal, intranatal, or neonatal. Antenatal may be due to placental abnormality or cord abnormality or twin-to-twin transfusion, which occur in the monozygotic monochronic twin pregnancy. The difference in the hemoglobin is more than 4 grams. The donor baby is smaller and anemic and may suffer from congestive heart failure, while the recipient twin is usually larger and polythoric with hyperviscosity. Hemorrhage during delivery may be due to placental causes or cord abnormalities or obstetric trauma. In the neonatal period, it may be due to caput succedaneum or cephal hematoma or intracranial hemorrhage or defect in the hemostasis, like Professor Abdel Mohsen said, or iatrogenic blood loss. The second pathophysiology is increased erythrocyte destructions or hemolysis, and this may be due to acquired or intrinsic factor like immune hemolytic anemia, ABO incompatibility, RH incompatibility, or maternal disease like collagen vascular disease, or acquired caused by infections, either bacterial or viral, or due to vitamin E deficiency, or congenital abnormalities of the RBCs, This abnormality may include the red cell membranes like spherocytosis, elliptocytosis, or enzymes or thalassemia like alpha thalassemia, gamma thalassemia, or unstable hemoglobinopathies. Another etiology also is decreased production, which may be physiological causes like the late anemia of hemolytic disease of the newborn, or infiltration like leukemia, neuroblastoma, histiocytosis, or nutritional or acquired suppression of the bone marrow by drug or infection, or constitutional like Diamond-Blackfan syndromes. So how can we diagnose anemia in the neonatal period? Like any disease in the medicine, you must start by meticulous history taking, by careful physical examination and laboratory investigations. Maternal history is very important, it including prenatal exposure to infection or medicine, nutritional deficiency, maternal disease like systemic lupus erythematosus or vaginal biliary. Obstetric history of critical importance to know the details of labor, the presentations of the baby, is there instrumental delivery or associated birth injury, family history of hematological disease, or similarly affected baby may suspect hemolytic disease of the newborn. Physical examination is very important. Start by evaluation of the vital sign of the baby. Tachycardia or hypotension signify blood loss and needs urgent management. The color is very important. Jaundice with hemolysis, ill newborn with pallor suggests asphyxia or sepsis. Skin for ecchymosis or petechiae suggests bleeding tendency. Also search for any congenital abnormalities for hypoplastic or organomegaly for hemolysis and congenital infections. Age of onset of anemia is very important. The baby presented with anemia at birth is emergency. It may be due to blood loss or like twin-to-twin or birth injury, and this child needs urgent blood transfusion in the delivery room, or due to alloimmunizations. In the first 24 hours may be internal hemorrhage or other causes of hemolysis, while after 1 week, usually anemia of prematurity or hypoplastic or congenital hemoglobinopathies or other causes. What about the laboratory diagnosis? CBC, meticulous care, meticulous evaluations of the CBC is very important. Look for the hemoglobin and the RBCs indices, macrocytic with aplastic anemia, while microcytic signify chronic intrauterine blood loss, and normocytic with hemolysis or hemorrhage. Reticulocytic count increased with hemolysis and hemorrhage, while decreased with aplastic anemia or suppression of the bone marrow. Peripheral blood smear is very important to look for abnormalities of the shape of the RBCs like spherocytosis, to look for target cells with hemoglobinopathies, or also to look for fragmented RBCs. Don't forget to look for white blood cell count and the platelet also. Maternal and infant blood type is very important. Combis, serum, bilirubin, and other investigations according to your suspicious. So this algorithm for diagnosis of neonatal anemia, reticulocytic count, if decreased, it may be due to decreased production like Diamond-Blackfan or anemia of prematurity, while increased suggests hemolysis. So do Combis test. If Combis test positive, RHA incompatibility or ABO incompatibility. If negative, look for the MCV. Low MCV may be chronic intrauterine blood loss or alpha and gamma thalassemia. If normal or increased, do peripheral blood smear to detect abnormalities of the shape. But if not present, it may be hemolysis like other causes of congenital abnormalities of the RBCs like enzymopathy, or due to infections or other causes like galactosemia or hypothyroidism or blood loss. Management, it is very important to balance between the advantage of blood transfusions and also the risk of blood transfusion, especially in preterm baby, where there's several risks like necrotizing enterocolitis, like bronchopulmonary dysplasia. Blood transfusion is life-saving, but it is very important to look also for the risk of blood transfusions. It may be simple transfusion for acute hemorrhage. We can start by whole blood, 15 to 20 milli per kg. Please draw the diagnostic test before transfusion. Transfusion guidelines differ widely, but mostly it depends on the hemoglobin and the condition. It depends on the hemoglobins and the clinical condition of the infant, focusing on the degree of respiratory failure. This is one of the guidelines. For example, if the hemoglobin less than 7, you can transfuse. But if it is less than 8, look for the other features like apnea, tachycardia, or bradycardia. Another important guidelines, this is the comparison of the British guideline, Australian guidelines, and other guidelines. So what to transfuse? It's used usually from 5 to 20, leuko-irradiated. What is the transfusion threshold use? High transfusions, liberal versus low transfusion. This systematic review and the meta-analysis assess the restrictive versus liberal transfusions in the low birth weight, and they found that restrictive transfusion may be utilized without increased risk of death or major short-term neonatal morbidities.
Professor Leila, we have 1 minute, so about to close, please. Thank you.
I can do conclusion. No problem for me.
Thank you very much.
Okay. This is my conclusion. Anemia in the newborn is the commonest hematological problem. Preterm baby is more liable to suffer from anemia. RBC transfusion remains a primary treatment of anemia in the neonatal period, using a single donor program of neonate to limit the donor exposure. Adherence to transfusion guidelines are important strategies to reduce the need for transfusion. And please, preventive measure is also very important. And thank you.
Thank you, Professor Dr. Leila Sharif, for this very useful and very up-to-date lecture, neonatal anemia. I'm neonatology, and I was so pleased to hear from you this lecture. Thank you very much. Now I'm going to my colleague and little sister. I told her little sister because she's my sister and she's much younger than me. Professor Rania Al-Farrash, she's a professor of pediatric and neonatology consultant at Children's Hospital. Rania Al-Farrash has many international publications. She's also a member for neonatal resuscitation program as an instructor, and also for neonatal life support instructor. She's one of our active neonatal professors, more than her older sisters. I think we are going to hear a very important and good presentation about neonatal thrombotic disorders. You are welcome, Rania Farrash.
Thank you, Dr. Safa. السكرين باينة؟
تمام زي الفل.
اتفضلي يا حبيبتي.
Good afternoon. I would like to express my deepest gratitude to Professor Mohsen and the Espho board for such an honorable invitation. Today, I'm going to talk about the story of success between our NICU team and the pediatric hematology team. We are going to talk about the incidence, risk factor, classification, investigation, and treatment of neonatal thrombosis. Actually, neonatal thromboembolic event is not uncommon. It represents 5.1 per 100,000 live births, 2.4 per 1,000 NICU admission. And why this happens? It happens because neonates are at high risk of thrombotic insult. As Professor Dr. Abdel Mohsen said, that neonates are having a prothrombotic phenotype. Full-term neonates have lower concentration of procoagulant proteins, lower naturally occurring inhibitors of coagulation, and also the fibrinolytic system reaching around 30 to 50% of the adult values. These conditions are more pronounced in preterm infant. The coagulation system is dynamic during the first few weeks of life. However, despite all these differences, normal, healthy, full-term neonate doesn't show a manifestation of thromboembolism. There must be a trigger or an add-on risk factor, whether maternal risk factors like bad obstetric histories, abortions, and abruptio placenta, intrauterine fetal death, maternal diabetes, cocaine abuse, premature rupture of membrane, and chorioamnionitis. What about neonatal risk factor? The most important neonatal risk factor is catheter-related. Central line catheter-related thromboembolism is very common. Also, during sepsis and DIC, there's acquired deficiency of protein C and S, hypoxic ischemic encephalopathy, polycythemia in 2020 transfusion, and intrauterine growth retardation. So, how we can classify neonatal thrombosis? There are different ways of classification, whether etiological, is it hereditary or acquired, fetal or neonatal, arterial or venous thrombosis. Also, the actual affected blood vessel will differ, and we will see how different the protocol of management with our case scenario. This is our first case. Let's call her Hagar. Hagar is a full-term female, 2.9 kilograms, normal vaginal delivery to an eventful pregnancy and normal Apgar score. The mother has a bad obstetric history of 3 intrauterine fetal deaths, 1 abortion, and 1 neonatal death, only 1 living female. The mother noticed first day of life bilateral twitches of Hagar's upper eyelids. On the day 3 of life, she developed fever. She was presented to us actually active, crying, conscious, with good suckling, but her neurological evaluation showed evidence of right-sided hemiparesis, unequal moro, upper motor neuron facial palsy with no other abnormal movement. So the routine investigation was done, showing nothing. That's directed us to what we call perinatal stroke. What's perinatal stroke? It's an thromboembolic incidence starting from the fetal life till early neonatal life. The etiology, we are not concerned with the hemorrhagic causes. Here we are concerned with the ischemic stroke or cerebrovenous thrombosis. Actually, perinatal stroke is 17 times much more common compared to the pediatric stroke. But the good news that more than 95% of those affected infants will survive into adulthood. So what's next? Do you think that we should investigate deeply through the thrombophilia screening? Actually, no. As we have discussed a few months ago, that the thrombophilia evaluation is misleading, expensive, requires repetition, and also not diagnostic. So instead of doing all that expensive screening technique, we may only direct it to maternal or parent screening, especially the mother with antiphospholipid and anti-cardiolipin antibodies. This is why we should screen the parents for inherited thrombophilias, which is the most common of which factor V Leiden mutation, prothrombin gene mutation, and methyl tetrahydrofolate gene mutation. This is our patient. We are directed to neuroimaging. This is a MRI showing low signals at T1, loss of differentiation between the gray and white matter, and low signals at T1, high intensity signals at T2, denoting recent infarction. Actually, the middle cerebral artery infarctions account, non-hemorrhagic infarction as we see here, account for almost 83% of perinatal stroke. 67 of them occurring in the left middle cerebral artery. Keeping in mind that in the right-handed person, the left hemisphere dominate with the Broca's and vernix area responsible for language and speech development. The American Heart Association and American Stroke Association published in 2008 and again in 2019 a management statement that eliminated 3 main stages of management. First of them is supportive measures, including correction of fluid status, correction of anemia, anticonvulsant to control the seizures. So what about thrombolytic therapy or anticoagulant? The patient has a stroke. Are we gonna give him or her an anticoagulant therapy? Actually, no, because this is a transient condition that most probably will not recur again, except in few conditions. If she had a complex heart disease, associated systemic emboli, or documented severe thrombophilia like bilateral, heterogeneous protein C deficiency. So there is no anticoagulation therapy indicated in such cases. Appropriate rehabilitation and physiotherapy and psychological assessments with long-term follow-up. And this is a happy ending of our first story. Hajar is here almost 3 years old, active and healthy, with the permission of her parents for those pictures. Our second baby is 36 weeks male, one of twin, in vitro fertilization. Immediately as we see after delivery, his picture showing bilateral blanching of both lower limbs and absent femoral pulsation, discrepancy between the upper and lower limb blood pressure. So we was doing an urgent lower limb duplex showing a thrombus in the abdominal aorta below the renal artery till the common iliac arteries. Again, what should we do? We should dig more deeply for history. The patient here has a history, mother has a history of recurrent abortion. His uncle died at the age of 20, and this is, instead of doing the screen for the baby, we do it for the patient. That the thrombophilia gene study to the family showing that at least 2 genes are affected in the father's family. So what is the dilemma here? We have consulted the vascular surgery. This is a major for thrombectomy, I mean, major surgery with high FDPs, low platelet count, no available neonatal catheter. Can we use the coronary catheter instead? It's an option. So we started medical treatment directed to the umbilical artery. Why? To be more near the abdominal aorta. Again, this is one of the indications of thrombolytic therapy, because thrombolytic therapy is not recommended unless a major vessel occlusion compromising a limb or an organ, which should be monitored for significant risk of bleeding. And when we decided to use, the best or the drug of choice is alteplase or recombinant tissue plasminogen activator. I will not talk deeply about the doses, but the most important thing I want to highlight that there is adjunct to treatment. We should use a fresh frozen plasma, 10 milliliter per kg, in order to supply plasminogen for the drug to act well. Again, when we use anticoagulation, low molecular weight heparin, rather preferable drug for use in neonate instead of unfractionated heparin.
Professor Radia Hanem, you have 1 minute. Okay. Thank you.
It had a predictable response, less laboratory monitoring, and less immune-mediated reaction. And for this patient, unfortunately, this patient died. But for the last patient, 40 weeks male, infant of diabetic, loose discoloration of both lower limb after cannula insertion, with a duplex showing decreased damped velocity in both limbs. The baseline testing, as we have discussed before, and this is the management. This is an indication of thrombolytic therapy, starting alteplase, but we have to exclude intracranial hemorrhage, transcranial ultrasound, platelet count should be done, and more than 50,000 15,000. And if we are going to start heparin, we have to be sure that there is no contraindication. If there is contraindication, literature said no treatment. However, we've used heridine, which is a direct thrombin inhibitor, in another case with good results.
Conclude, please.
Finally, this is
you have to
our
conclude.
case,
You have to
happily,
conclude. Thank you.
and our take-home message that it is transient, that not required significant investigation, only supportive measures, because of the risk of recurrence is low, and we have to know the localization of the thrombosis before starting antithrombotic therapy. Baseline testing and low molecular weight is our drug of choice. If we are going to use thrombolytic therapy, RCPA is the thrombolytic of choice. Thank you. This is our team. Thank you.
Thank you, Professor Rania.
Professor Tamer.
Yeah.
Yeah,
Thank you,
introduce
Dr.
Professor Mohsen.
Okay, thank you, Dr. Rania, for this interesting presentation. It's a great pleasure for me, an honor and privilege to present the real hero for the Espho great success story for almost more than 20 years. On behalf of all the Egyptian pediatric hematologists and oncologists, I'd like to thank Dr. Mohsen for this great conference and the marvelous efforts he exerts to bring such a conference to such an international level. Dr. Mohsen is going to speak about anemia beyond the neonates. Please, Dr. Mohsen.
Thank you very much, Tamer, the chairpersons. Gafi is not allowing me to share the video, so he will try that. I'll go quickly. Anemia beyond neonates. Okay, so I stop sharing and I start again. Start my video. Okay, that's great. Good news. Okay, and I come back and I think it will not take time. Do I share the presentation or not yet? Do you see the presentation, Tamer?
Yes.
Do you see?
Yes.
No?
Yes.
Okay. I have no conflict. Anemia beyond neonatal period. Between 2 and 6 months is not common. Anemia is not common. And sometimes we missed it in the clinic. And only very sharp and smart physicians could catch anemia at that age. It is extension mostly from neonatal period because of RH or ABO incompatibility. However, iron deficiency anemia is uncommon in this period. G6PD also, unless the mother is deficient and eat fava beans. Beta thalassemia major, I see few patients at the age of 3-4 months, they are severe, very severe. However, congenital spherocytosis and pyruvate kinase could present in that age. 6 to 36 months is the age of anemia. Common causes are, the commonest is iron deficiency anemia, 60-70%, mainly due to high milk consumption or due to continuation of the anemia of the neonatal and postneonatal period. G6PD is 5 to 10%, beta thalassemia minor 5 to 10%, and now alpha thalassemia is coming to the front picture with 5%. Chronic diseases, rheumatoid and hypothyroidism. The iron is either heme or non-heme iron, and the good food, dates, tomatoes, lentils, and of course liver and mussels are very good. Guidelines on the management of iron deficiency start with the history. Good history, either wrong weaning, prolonged milk feeding, high consumption of milk, or others, which we will see now. After the history, examination, then investigations. To treat iron deficiency, most of the guidelines ask for oral route if possible. Treatment targets for iron deficiency included an increased hemoglobin of 12. Don't be satisfied with 10 or 11. Only 1/3 of guidelines recommend to do transferrin saturation as a target, proposing various thresholds ranging from 30 to 50%. Iron supplementation only administered intravenously in one half of the guidelines in chronic kidney disease and chemotherapy-induced anemia, but all the others, they give oral iron. The iron deficiency markers on the top, one third only of the treatment episodes, patient has pre-treatment assessment. Not every patient has serum ferritin, and 15% have post-treatment only, and only 7% have initial and post-treatment. The post-treatment measures of iron supply markers, transferrin saturation and serum ferritin, was more frequent done in chronic inflammatory disease in 40% versus 30% in nutritional. Serum ferritin was measured 30 times more than transferrin saturation. Transferrin saturation is a little bit more expensive because we have to check only the serum iron but total iron binding capacity, but it is also an important test. Among 100,000 were treated at least once with iron therapy, 99.2% receive oral iron. And the median of treatment is around 3 months, from 1 day to almost 10 years. 600 patients, that's to say 0.6, 6%, أقل من 1% received both oral and intravenous iron, and only 0.2, 2 في الألف, were treated exclusively with intravenous. Most of them are chronic kidney disease, heart disease, and chemotherapy-induced anemia. The American Academy of Pediatrics recommend to screen all children around 12 months for the presence of anemia and additional screening at the age of 5. WHO recommends universal iron supplementation in the region. In any country with iron deficiency around 50%, iron supplementation around 1 year is mandatory. The etiology of iron deficiency anemia in infancy, mainly low birth weight and prematurity, exclusive milk feeding beyond 6 months. The single most common cause of iron deficiency is excess milk consumption. However, cow milk protein allergy is an cause. Blood loss in 30% linked to cow milk protein allergy, usually around between 6 and 24 months. Michel's diverticulum around 6 months to 12 months. Drugs, and of course, menorrhagia come on the top of the list in pubertal females. Malabsorption 30%, like celiac disease, H. pylori, GIT, parasitic infestation. Iron replacement therapy is always mandatory whenever I am treating the underlying condition. Serum ferritin, uncomplicated iron deficiency can be assessed by not only serum ferritin, but by transferrin saturation. A low serum ferritin below 30 is diagnostic for absolute iron deficiency, while in inflammation, serum ferritin around 100 is strongly suggestive of absolute iron deficiency due to restrictive type of iron deficiency, iron refractory. We could never imagine that a baby come with 6.5. You have to look to the MCV, 47. This is not a case of G6PD because the mother didn't notice the anemia except a few days ago. When you look to the total iron binding capacity and serum iron, the transferrin saturation is less than 1%. It should be 30%. And serum ferritin is 1. So it is unnecessary to give blood transfusion, you give iron. Another case, hemoglobin of 5. If you miss the MCV of 50 and MCH of 12, you are going to suspect G6PD and the mother give a misleading history. When you do serum ferritin and iron is 30, but total iron binding capacity is 600 and transferrin saturation is 5%. No jaundice, so no hemolysis, no G6PD, and ferritin is 3.8. These two patients, they go fine with oral iron for 6 months. After 1 month, they become 9 or 10, and in 3 months, they become 12. They continue for 6 to 12 months therapy. The most important in the anemia is the hypochromic, normochromic, normocytic. In hypochromic macrocytic anemia is around 2/3 or more. We have to do iron profile, iron challenge test, hemoglobin electrophoresis, transferrin level, bone marrow only to look for iron stain if you suspect sideroblastic anemia. And in iron refractory iron deficiency anemia, IRIDA, will be discussed by Professor Hoda Hassab in Boursaid next Thursday, we do genetic study. This is another case. Rukaya, Professor Charlotte, I see your photo. You are welcome. Rukaya, I asked you last year in the Harry Potter of Professor Tantawi about this child. The serum iron at one stage of her treatment was 13, serum ferritin 1.5, and now she has an immune problem. She is cured, but after she cured, she has iron deficiency anemia. We continue with iron for 3 months. Pitfalls in the approach to anemia, if common causes of pitfalls, coexistence of two common problems, iron deficiency anemia, 60%, beta thalassemia, minor beta or alpha in 10%. One steady state of special case of TEC, which is transient erythroblastopenia of childhood. It is rare, but it is there. Like every year, I see 4 or 5 cases. Mild disease as mild G6PD, rare diagnostic dilemma, IRIDA and sideroblastic anemia. Clinical manifestations of iron deficiency anemia, not only growth affection and fatigue, but PECCA. PECCA is very important. It is pathognomonic and disappear within 1 to 2 weeks. Microdispersed iron is different from the traditional iron. Traditional iron, the bioavailability is 1 to 5% only. It hurts the stomach. It is not absorbed easily in the intestine, and it has competition in the blood. Microdispersed iron, maximum bioavailability, it does not hurt the stomach, good for absorption in the intestine, and no competition in the blood. Microdispersed iron in a month could increase hemoglobin by 1 to 2 grams and elevate ferritin level by 50%. It has not only the microdispersed iron, but microdispersed zinc, vitamin C, E, and vitamin B. Why I'm supporting this Ferrovella? Because it is a product which I dream that a product with iron and zinc and vitamin C and vitamin B, so it is good for the child. For prophylaxis, it could start from 9 months or 12 months, 1 teaspoon for less than 4 years, and 1 tablespoon for more than 4 years, but in treatment, double the dose. Take-home message: iron deficiency and iron deficiency anemia is so prevalent, sorry to say, in our area and in our practice. Please ask for CBC, not hemoglobin. Both hemoglobin and NDC should improve with iron therapy. Failure to obtain complete remission, investigate for underlying condition. Assess hemoglobin increment of 1 to 2 grams in 1 month, adequate microdispersed iron dose and course. Thank you very much. And we have Professor Galila has to close the session, and we start the next Harry Potter session.
Thank you so much, Professor Alfie, for this nice presentation. Sorry to make you takipnik and after running so quickly and fast in the last presentation. And for all of you, all the chairpersons and speakers, I would like to thank you all. Sorry for no time for question and answers, but maybe we meet later. And now we shift to the next session, and thank you so much. We'll leave the platform now. Thank you.
We will see Professor Tantawi will please present the co-chairs and share your presentation. We have co-chairs Professor Charlotte and Professor Pega and Azza. Azza, go ahead.
Yes. Good afternoon for everyone. Thank you very much. I have the pleasure and the honor to be chairperson in this. I hope it will be very much interesting session, the Harry Potter session. And we have 2 eminent chairpersons, Professor Antonio Piga, Professor of Pediatrics at Torino University and President of the Ethics Committee, San Luigi Gonzaga, Italy. His main professional activity is clinical medicine applied to hematology and pediatrics with strong orientation to genetic diseases. He developed the reference center for hemoglobinopathies of Piedmont region in Italy, and he acted as a dean of the School of Medicine at San Luigi University Hospital with the research activities focused on hemoglobinopathies, iron metabolism disorders, non-invasive methods of body iron quantification, drug development, especially iron chelators and erythropoiesis modulators. You are always welcome, Professor Piga. And the second eminent chairperson, Professor Dr. Charlotte Niemeyer. She was with us last year, and she is a professor of pediatric hematology and oncology in the Department of Pediatrics in the University of Freiburg. And she is having a very rich CV with a diversity of very strong positions, including the medical director of the Department of Pediatric Hematology Oncology Medical Center Freiburg in the University of Freiburg, the interim chair of the transfusion medicine at the University Medical Center Freiburg, the vice president of the University of Freiburg in Germany, the physician-in-chief in the Children's Hospital, University of Freiburg, and she is the founding member of the European Working Group of MDS in Childhood, and the vice chair of the executive board of the German-speaking Society of Pediatric Oncology and Hematology, and the chair of the Committee of the Promotion for Young Oncologists and Researchers of the German Cancer Aid. She's the vice president and member of the board of the German Cancer Aid, and in the ASH, she is the chair of the International Members Committee and the chair of the Scientific Committee of Blood Disorders in Childhood, and she's an elected member of the German Academy of Sciences. Very, very rich CV, very rich scientific life, and you are always welcome, and we are always making benefit of your presence and your science, Professor Piga and Professor Charlotte. I am going to start my presentation. I'm the first speaker. Okay, I hope I will not take time. Okay, I am Professor Azza Abdelgawad Tantawi. I'm Professor of Pediatrics, Pediatric Hematology, Oncology, and Shams University. I'm going to present very rapidly two cases to think about rare diseases, because rare diseases, although they are rare, but rare disease patients are numerous. These two patients, they have a nearly similar presentation with a delayed diagnosis. One of them was diagnosed, the patient H was diagnosed by the age of 14 months, while he already had manifestations started by the age of 4 months. While the patient A, he was diagnosed by the age of 18 months, while his initial manifestations started by the age of 7 months. Both of them had a huge progressive abdominal enlargement, hepatosplenomegaly, pallor, anemia, thrombocytopenia, starting very early. Both of them had frequent chest infections and were requiring transfusion and hospitalization, and both of them have delayed motor development. Let's go first to patient H. Patient H, when we are going to look at patient H, he presented to the hematology clinic in the December 2020. If you are going to look to his file and the previous investigations, we will see that all through the time, the investigations we were looking at, he was always having thrombocytopenia, which was progressive. His total leukocytic count was always elevated. The neutrophil count was always elevated. And if you are going to look to the monocytes, you will see the monocytes were always elevated. This child in September 2020, he made a bone marrow examination. It was normal cellular tri-lineage presentation, but active granulopoiesis, notable eosinophilia, increased blood cells, 7% of all nucleated cells. And the conclusion was that he had active marrow with defective thrombopoiesis, increased blood cells, possibly attributed to repeated bacterial infections. And when we saw him in December 2020, his liver was 12.3 by sonar, while the spleen was 14.4. Think that this child, his weight was just 9 kilograms. So this is a huge hepatosplenomegaly for this child. This child was initially referred to the immunologist because of the recurrent infections. And flow cytometry quantitative was done for leukocyte oxidative burst in the peripheral blood sample and showed normal response. They wanted to exclude chronic granulomatous disease and the leukocyte adhesion deficiency syndromes because of the leukocytosis and recurrent infections suggestive of primary immune deficiency. So concerning chronic granulomatous disease, this flow cytometry of leukocyte oxidative burst showed a normal response, and his DHR test also was negative, so it was not chronic granulomatous disease. For the leukocyte adhesion deficiency syndromes, he had a flow cytometric assessment of the CD18, CD11B, and CD15, which were also negative. So he was not a leukocyte adhesion deficiency syndrome. And immunoglobulin assay was done. It revealed normal IgG, IgM, slightly decreased IgA for the patient age reference ranges. And for the T and B helper lymphocytes, they were all almost in the normal range, even the natural killer cells. So this patient was referred to our hematology clinic in December 2020. If you are going to look to the CBC, the 3 CBCs, which I have put, none of them revealed the presence of blast, but what was very striking is the monocytosis, which was evident in all the CBCs with the patient. The monocytosis is striking. The last one, the monocytes, was 7,630, and the neutrophils were 11,980. The bone marrow was repeated in January 2021, and it revealed no obvious atypical or immature cellular biopsy. I hope that you are hearing me properly. I don't have internet problem. We thought that there is a possibility that this child is a juvenile myelomonocytic leukemia because of the prominent monocytosis and the leukocytosis and the huge splenomegaly reaching to the right iliac fossa. And we looked at these criteria of the GMML. As you see, this is the criteria of 2009. They all should be present. Absence of the translocation 922, absolute monocyte more than 1,000, and less than 20% blast in the bone marrow. So we did the translocation 922, and it reveals to be negative. Plus at least 2 of the following: circulating myeloid precursors, which are not present. White BC is more than 10,000, which is present. Increased fetal hemoglobin. We did a hemoglobin electrophoresis, and the fetal hemoglobin was normal, and in vitro hypersensitivity to GM-CSF, which could not be done. So when we are rehearsing, there is a new criteria for the GMML. And if you look, there are 3 categories. Category 1 is absence of BCR ABL1 fusion gene. We did this, and it proved to be absent. More than 1,000 circulating monocytes, less than 20% blast, peripheral blood and marrow, and splenomegaly. To be the diagnostic, we need either one of category 2, which includes mutation analysis for KRAS and RAS, or PTNP11, clinical diagnosis of NF neurofibromatosis 1 or neurofibromatosis 1 gene mutation, and germline CBL mutation. If none is present, you go to category 3 for a monosomy 7, or you have to search for 2 of circulating myeloid or erythroid precursors, increased fetal hemoglobin, hyperphosphorylation of the STAT5, and hypersensitivity to GM-CSF. Because we were highly suspicious, and we said, okay, we need an expert opinion, and we referred to our dear Professor Ala El-Haddad, Professor of Pediatric Oncology, and we did with him at 57 Hospital the PTPN11 mutation, which proved to be present. And we reinforced that we don't have a translocation 922, the BCR ABL, normal karyotype, hemoglobin electrophoresis normal. So this patient was diagnosed as having solved juvenile myelomonocytic leukemia with a delayed diagnosis. Let's look to the other patient, the patient A. This patient having huge organomegaly, hepatosplenomegaly, it's terrible. He developed this condition since 7 months. He was diagnosed by 18 months. His CBC, only anemia, thrombocytopenia, total leukocytic count was normal. Initially, when he came, he had the bone marrow examination revealing no abnormal cells. This was by the age of 14 months. There is no consanguinity between his parents. So please think of lipid storage disease, especially Gaucher anemia peak, even if no abnormal cells in the bone marrow, because we do have 20% of our patients with Gaucher in our series, they don't have Gaucher cells in the bone marrow. So how you are in suspect, what you should do, you should use a enzyme SE. The enzyme SE is done what we call the leukocyte acid beta glucosidase enzyme or beta glucocerebrosidase enzyme. It was low in this patient. When this enzyme is defective, the glucocerebroside, the lipid accumulates in the macrophages, and there is an increase of one of the biomarker, which is the chitotriosidase, which was elevated in this patient. But when you do this, you should exclude another disease, which is the Niemann-Pick. We do plasma sphingomyelinase SE always, because there may be some confusion. Plasma sphingomyelinase SE will be decreased if you have an Niemann-Pick type A or type B, but in type C, it will be normal, and you should go to molecular study. For this patient, now, after at the age of 18 months, there is Gaucher cells in the bone marrow, which are the macrophages with the glucocerebroside, and they have a typical picture. Okay, genotype for this patient was what we call L44P homozygous, which is common among our patients. So our patient was diagnosed as Gaucher disease. Which type of Gaucher disease? Type 1 is non-neuronopathic. Type 2 is acute neuronopathic. Yes. Yes. Yes, yes, I will finish. Type 2 is acute neuronopathic, and type 3 is subacute neuronopathic, which is common among our patients. So this patient is type 3 Gaucher disease. When he came late for diagnosis and for late treatment, he had complications like pericardial effusion and peribronchial pulmonary infiltrates. He improved on enzyme replacement therapy. There is a treatment. So finally, it is solved. It is a Gaucher disease type 3. So my message is always think of rare diseases. Awareness is the clue for early diagnosis and management. And thank you very much. We should be aware. We should think to be able to diagnose. Thank you. Okay.
Professor Azza, please present the next speaker.
I have the honor to present the next speaker. Yes, Professor Mohsen. Yes, I have the honor to present the next speaker, Professor Dr. Ahmed Mujahid, Professor of Pediatric Gastroenterology and Hepatology Unit, Mansoura University Children's Hospital, presenting very interesting case. I wished we could have the discussion after every case, but according to Professor Mahsen, we have to.
No, it's not true. If you find it is good, but not taking more time. So if each case, if it is 5 minutes or 4 minutes, is okay. If you'd like to go like this way, but okay. At the end, you just as a chair, you remind us with the case, then we go for the discussion. If you prefer the second.
Yes, it's okay. If any of the chairpersons have comments on the previous presentation, you are welcome. This will enrich our knowledge and experience.
Yeah, this is Charlotte Niemeyer. I have a question on the two cases,
Charlotte.
JMML and Gaucher.
Yes.
I would be curious, looking at the peripheral blood smear, whether you see some immature forms in the JMML, which you may not be able to see in the Gaucher. So in other words, could you discriminate between the two by looking at the peripheral blood smear and looking for immature myeloid and immature erythroid precursors? Or in other words, my hypothesis is that in the JMML, you find some immature forms which may be absent in the Gaucher. That's maybe
yes, Professor Charlotte, I was searching for that, really. And the patient who was JMML, I have put first, let's think, if he is not it is not GMML, we are going to think of storage diseases. But usually in storage diseases, we don't have such hyperleukocytosis. It's not a feature. Even we have either normal leukocyte count, and rarely neutropenia and leukopenia, but we don't see the leukocytosis. We have many patients of Gaucher disease in Egypt, we are treating them since more than 20 years.
No,
and actually, I insisted there was no immature cells in the peripheral blood in the patient of GMML. That's why I believe this was the difficulty in its diagnosis, in his diagnosis.
yeah, I think the leukocyte count in JMML often is not very high. And if you can distinguish, I think you might be able to distinguish by the immature forms, because there are only about 3% of JMML who do not have any immature forms on peripheral blood count. This was my only comment.
Okay, thank you very much. Thank you. Okay, we are all ears to follow with Professor Ahmed Mujahid.
Good evening.
From Mansoura, Professor Ahmed. Good evening.
Can you hear me?
Yes.
Unfortunately, the video is blocked by the host. If he can allow to share the video as well, it will be very nice.
Is it possible? Adiga?
Yes, working on it. Yes.
Yes, thank you.
Yes, you can start, Professor, and we are working on it.
Professor Ahmed, you can start.
Okay, okay. I'm still blocked. The video
they are
is still
working
blocked.
on the
Okay.
video. Yes, yes, you can start.
Okay. It is a great pleasure to join you in this wonderful meeting, and thanks for you all for this nice invitation. Today I'm going to present a humble presentation, Hepatic Ghosts, the Old Riddle, and despite not being fond of mysterious titles, but it might fit a Harry Potter session. Our story today is a 10 years old child presented with a big abdominal pain for a few months. He had repeated medical consultations and the previous tertiary care hospital admission without definite diagnosis. He had no any other symptoms or fever or joint pains, no history of any alarming GI symptoms. He had performed abdominal ultrasound and revealed a multifocal liver lesion. Furthermore, abdominal MRI was done and the patient was admitted at our center for further evaluation. The physical examination was quite normal. You can say that his gross parameters were average. His general examination apparently healthy, well looking, no pallor, no jaundice, no stigmata of hepatic decompensation, no skin manifestation, no lymphadenopathy, no musculoskeletal abnormalities. Abdominal examination, just a mild enlarged liver with dullness of the TROPS area. This is his abdominal ultrasound showing moderate hepatic enlargement with a slightly echogenic parenchyma and one small focal lesion here in the left lobe and another one in the right lobe, and mild splenic enlargement and solitary peripancreatic lymph nodes enlargement. The MRI showed enlarged liver with multiple variable size hepatic focal lesions and with homogeneous enhancement in post-contrast study. This is a post-contrast study, and this is the pre-contrast study. So this liver is hosted with multifocal lesions, and we are trying to search for a light to reach the diagnosis. So what might be the differential of these hepatic lesions? We have to consider if this liver is a liver with a chronic liver disease, the general condition and the constitutional symptoms suggestive of malignancy patient, the immune status, any stigmata of immune deficiency, specific infections or infestations, the lab workup and the tumor markers, the imaging findings, and finally tissue diagnosis when required. This is not an exhaustive list of the possible differential diagnoses of multifocal hepatic lesion in children. Starting with benign lesions like infantile hepatic hemangioma and infantile hepatic hemangioendothelioma, focal nodular hyperplasia, nodular regenerative hyperplasia, hepatocellular adenoma, particularly in patients with glycogen storage disease, angiolipoma in patients with tuberous sclerosis, Some malignant conditions like hepatoblastoma, hepatocellular carcinoma, particularly in chronic liver patients, particularly those with tyrosinemia and progressive familial intrahepatic cholestasis type 3, embryonal sarcomas, metastatic neuroblastoma, Wilms, and lymphoma. And of course, this is your field as a pediatric hematologist and oncologist. Some infectious causes like FCCs, particularly in immunosuppressed individuals, cat scratch disease, tuberculosis, hydatid disease, and miscellaneous causes like biliosis hepatis. In our patient, the basic investigation revealed the CBC, the hemoglobin is normal, 11.2, arbitrary normal, mild anemia, platelet count normal, 491. The white blood cell count ranged from 13,000 to 16,000, and the eosinophils were from 10 to 30% of the total count. The liver function tests were normal liver enzymes, normal synthetic function, and the ESR was high. The first hour 62, second hour 160, normal LDH and alpha fetoprotein. Stool analysis for ova was nil, and for protozoa there is some Giardia lambelia. So can you point here for a key that might resolve this riddle? Really, the eosinophilia. The eosinophilic count was high in this patient, so we have to search for the causes of eosinophilia in these patients. The general look of the patient here and the absence of constitutional symptoms makes the possibility of malignancy is still it is less possible diagnosis. We evaluated the patient with serology for two common parasitic infestation, bilharziasis, which is still present. It become more or less rare in our locality, but it's still present on some occasions. And for fasciolasis and for hydatid disease, the anti-bilharzia antibody was 100, the titer 100 over 30, 320. Revision notice pointed that this child had no bleeding rectum nor dysentery, and he had developed a new hobby of fishing in the water lakes. So he is going to swim and to fish in water lakes for the last 4 or 6 months. And we requested a specific stool analysis with the concentration method, and it revealed schistosoma mansoni. Schistosoma is one of the familiar and the famous infection that plagued Egypt for many years, even dating since the pharaohs, the ancient Egyptians. These are two mummies in the Museum of Manchester that had been proven to have schistosomiasis. Colonoscopy revealed the presence of bilharzial colitis with bilharzial polyps, and biopsies and snare bolobectomy of some of these polyps revealed the presence of active bilharzial colitis. You can see here, this is a bilharzial granuloma, and this is the Mansoni ova in the middle of the granuloma. And also, this is a section from a bilharzial polyp. The patient was discharged after giving praziquantel 40 milligram per kg single dose that had been repeated after 1 month, and regression was noticed in the size of the focal lesions corresponding to a decline in peripheral eosinophilic counts. This is the ultrasound before, and this is the ultrasound after treatment, after 6 months almost of treatment. And you can see here that there is no further focal lesions. This is the MRI before treatment, and this is the CT scan after treatment with disappearance of focal lesions. And the lab follow-up shows normalization of eosinophilic count, drop of ESR, and no further Manson-I ova in the stool. This is the focal eosinophilic hepatic necrosis, focal eosinophilic hepatic necrosis, or eosinophilic-related hepatic necrosis, or eosinophilic hepatic necrosis. It is a focal hepatic lesions caused by the eosinophils related to tissue damage, and it is associated with various eosinophilic-related conditions like parasitic infestations, allergic reactions, neoplasms, and hypereosinophilic syndrome. And the eosinophilic infiltrates produce some eosinophilic major basic proteins and eosinophilic cationic protein that can lead to local thromboembolic phenomena causing tissue damage. And these lesions are very important because they are constitute a differential diagnosis of a more adverse conditions. This is one published article about the focal eosinophilic infiltrate in the liver, the radiologic findings. And this is an adult series describing 20 patients, and they were 18 males and 2 females. The mean age was 50 years, and on follow-up for almost 6.4 months, 18 patients showed regression of these focal lesions. Among these 18 patients, complete regression had been achieved in 14 patients, partial regression in 2 patients, and no change in 2 patients. And some of them had regressed, the majority regressed without treatment, and 4 had the focal lesion regressed with treatment with praziquantel, as in our series. Perhaps they have similar parasitic infestations. This is another case report showing hypereosinophilia associated with multiple masses in the liver. And you can see that these are the similar MRI findings in our case. And this is the first report of bilharzial infection presenting with focal hepatic lesion in a 27 years old Caucasian females that had a trip to an African countries, Kenya, Tanzania, and Zambia, and had focal hepatic necrosis secondary.
Professor Ahmed Bey, we have the honor. You have 1 minute. Thank you very much.
Take-home message: focal hepatic lesions constitute a diagnostic challenge, and the multidisciplinary team involving oncologists, hepatologists, infectious disease specialists, radiologists is crucial for proper management. Meticulous, careful evaluation and interpretation of investigations is a must. Many benign and regressive causes exist. Thank you very much.
Thank you very much, Professor Ahmed Megahed. It's very interesting. We should never forget about bilharziasis. Very interesting presentation. Before I present the next speaker, I should acknowledge the efforts of our coordinators, Professor Iman Raga, Professor of Pediatric Hematology Oncology, and Professor Muhammad Tarif, Professor of Clinical Pathology and Hematology. They did a lot of effort to make this session successful. Thanks a lot for them. I'm going to present the next speaker. The next speaker is Dr. Islam Al-Hawari, and Dr. Islam Al-Hawari is a lecturer of pediatric hematology and bone marrow transplantation, Tanta University, presenting the mystery of lymphadenopathy. اتفضلي حبيبتي، اتفضلي دكتور إسلام.
Thank you, Dr. Azza. We are ready, thank you. I'd like to thank the organizing committee and Dr. Mohsen, and the special thanks to you, Dr. Azza, for your continuous support. Dear chairpersons, I'd like to present a case about a mystery of lymphadenopathy, starting with a patient who is aged 7 years old, presented by fever 2 weeks, about 40 degrees, with abdominal pain and abdominal distension, bone aches, night sweating, and fatigue with loss of appetite. His medical history was insignificant, apart from a lacrimal gland problem that needed some surgical intervention. We don't know about it a lot, but it was 1 year ago. This patient, when presented for initial evaluation, he looked ill, toxic, with general bad condition, with pallor and splenomegaly about 11 centimeters below the left costal margin, and the liver was palpable about 7 centimeters in the mid-clavicular line below the costal margin. His first CBC showed microcytic hyperchromic anemia with almost normal platelet count, but the TLC showed leukopenia, and his reticulocytic count was 3.7. He was admitted for further evaluation, and at that time, a patient with bad general condition, hepatosplenomegaly, and biocytopenia, we started thinking of infection, malignancies, or immunological disorders. So we started from there. We started screening for infections, but everything came normal. His urine analysis was normal, no typhoid, no brucellosis, toxoplasmosis were negative, Epstein-Barr, cytomegalovirus, hepatitis C and B, and HIV also was negative. And just for your knowledge, we repeated these investigations again for a reason I'm going to mention later on. Other organ and system functions were satisfactory, normal coagulation profile, liver and renal function were normal, electrolytes normal, ESR 11 in the first hour and 21 millimeters in the second hour. The microcytic hyperchromic anemia is still showing in the CBC with leukopenia, normal serum ferritin, and the electrophoresis excluded iron deficiency anemia and the chronic hemolytic anemias, and LDH was high, about 892 units per liter. A bone marrow aspiration was done, revealing a normal cellular marrow with no abnormal cells. His ultrasound at admission showed moderate hepatomegaly and splenomegaly that confirmed our clinical findings, but there was hypoechoic focal lesions in the spleen with enlarged retroperitoneal lymph nodes. So the report came saying it's most likely lymphoma. If it is lymphoma, we need to evaluate the other lymph node groups and to go further for screening at the site where we can take a biopsy. An abdominal MRI confirmed the findings of hepatosplenomegaly, but no focal lesion this time. This was a week interval between the ultrasound and the MRI. A bulky retroperitoneal nodes present at the para-aortic, aortocaval, celiac, and porta hepatis, globular in shape. The largest was at the para-aortic region, about 2.5 by 1.2 centimeters in diameter. His chest CT revealed bilateral patchy nodules seen at the posterior segment of the upper right lung lobe and the posterior segment of the left lower lung lobe. There was no mediastinal or hilar nodes, and as we are in the pandemic of COVID-19, these findings were not consistent with COVID infection. We went for a PET scan to see which site is the best for a biopsy to confirm or exclude lymphoma. We found multiple enlarged retroperitoneal nodes with radioactive glucose activity. This was the only site of activity. There was no activity in the liver or spleen, and other body organs were showing insignificant activity. So if this is going to be lymphoma, we need the tissue. Lymph node biopsy now, we have no choice but the retroperitoneal nodes. So we went for retroperitoneal lymph node biopsy, and there was some problems with the biopsy taking. The first time there was inadequate tissue, then the second time the patient was put under general anesthesia for a CT-guided biopsy. And we found a non-caseating granulomatous adenitis. The granulomas were surrounded by epithelioid histocytes with giant cells. The immunohistochemistry showed that CD20 are highlighting the follicles, and CD3 highlighting the interfollicular area. This immunohistochemistry pattern is consistent with tuberculosis. But this is a non-caseating granuloma, and the immunohistochemistry is consistent for tuberculosis. So the pathology report came saying this patient is recommended for confirmatory angiotensin-converting enzyme level to exclude sarcoidosis and other tests to confirm tuberculosis. We thought that the biopsy is going to give us a final solution, but no. The only fact that was proved by this biopsy is that there is no malignancy, but the non-caseating granuloma is still undefined, and tuberculosis and sarcoidosis are still possibilities. So we asked for tuberculin skin test, PCR for TB, and the quantiferon, but they came all negative. So we have a question mark. Is it not TB? And we also asked for ACE, and it came normal. So at this stage, still no malignancy, the caseating granuloma present, and the question markers are increasing around tuberculosis and sarcoidosis. At this point, clinically, the patient is having intermittent low-grade fever. The abdominal pain is still present and severe enough to interfere with his sleep, not responding to antispasmodics or analgesics. He's still having a profuse night sweating, and the appearance of new lymph nodes in the cervical region was intermittently present. Are we going to treat this patient as a case of tuberculosis, or this patient should be investigated for something else? Before starting anti-tuberculous treatment, we thought, why don't we go for autoimmune or immune deficiency disorders to be excluded? So we asked for immunoglobulin levels, which came normal, absolute and relative counts of T cells, B cells, and natural killer cells were all normal, except for a decreased CD4 and CD8 ratio. And this is the point where we reinvestigated the patients for viral infections and reinvestigated him for HIV again, and it came negative. A search of an autoimmune disorder included antinuclear, anti-double strand, C3 and C4, and they came normal. P-ANCA was negative, but C-ANCA is positive. We also searched for chronic granulomatous disease, but the DHR came normal. We searched for ALPS, but the double negative populations of T cells came within normal levels. So, can we now start anti-tuberculous treatment? This patient is suffering. He's still having all the initial symptoms, and the mother is anxious to give something to her baby. Why not we start anti-tuberculous treatment? What's with and what's against tuberculosis? At this point, we have the immunohistochemistry confirming tuberculosis, the pulmonary nodules on CT, the presence of night sweating, the persistent fatigue. But tuberculin test and PCR and the quantiferons are negative, and when we referred the patient to local health authorities for control of infectious diseases, a Zell-Nelson stain was done and came negative too. But the specialized chest hospital started to give anti-tuberculous treatment. They put him on a clinical scoring system, and they said this patient is eligible to start anti-tuberculous treatment. He started treatment in the first week of January this year, and they said they are going to give him triple therapy for 3 months, first as daily doses, then alternate day doses, and they will see the response. There is 1 week remaining of the treatment duration, but the patient is not doing well. On his latest evaluation, still severe abdominal pain, still night sweating, continuous fatigue, lymphadenopathy, hepatomegaly, and splenomegaly. The only thing that came normal is the CBC, which was corrected spontaneously. Hemoglobin came back to normal, and the TLC was normalized. The presence of abdominal pain urged us to do familial return fever gene.
Islam, you have 1 minute.
Okay. We did a FML fever gene and fecal calprotectin, and they also came negative. Still lymphadenopathy present in all the TCT scans. There is something that we cannot see. We went back to the biopsy, and why not this non-caseating granuloma is sarcoidosis. And the ECE level is not a sure exclusion criteria for sarcoidosis. If we think of sarcoidosis, it's a non-caseating granuloma, the lacrimal gland, all the problem that was present, the pulmonary lesions, the lymphadenopathy, hepatosplenomegaly, the abdominal pain, the negative tuberculin, but the serological analysis and the CD4-CD8 ratio are against sarcoidosis. I'm going to leave you with this question, is it sarcoidosis or not, especially that all literatures are saying that sarcoidosis is a diagnosis of exclusion. If we can reach a decision for this patient, I'm going to start treatment for sarcoidosis next week. If not, I'm waiting for your opinion. Thank you very much.
Thanks a lot, Dr. Islam. It was a very nice presentation. I want to just ask my colleagues, the chairpersons, if they want to make comments on the previous 2 cases. And for the audience, we are going to open the question and answer by the end of the session. Professor Charlotte, Professor Piga, if you have any comments on the last 2 cases.
Interesting cases. We don't see schistosomiasis here in Freiburg, but I'm very pleased to see that case. And the last case, I think it's a real mystery. Will be interesting to discuss later.
Yes, the same. I guess that you are on the right diagnosis, but you will tell us in the next future.
Yes, okay.
Thank you very much. In this case, I will present the next speaker. Next speaker is Dr. Nihal Hussain. Dr. Nihal is a very eminent lecturer in the pediatric and the pediatric hematology oncology unit in Children's Hospital Ain Shams University. Okay, we are listening. Dr. Nihal, تفضلي.
Thank you, dear Professor Azda, and thank you, dear Professor Mohsen Alfi, for giving me such a chance. I'm going to present three cases of undiagnosed anemia. Okay. Case 1 and 2, they had similar history. Both were a 5-month-old patient of first cousin consanguineous parent with uneventful perinatal history. Patient 1 was a female with positive history of sibling death at the age of 3 months by undiagnosed anemia with abdominal enlargement. However, patient 2 was a male patient with irrelevant family history. They were both presented with pallor, hepatosplenomegaly, and average body build. Their initial labs showed a high total leukocytic count. Patient 1 was 50,000, while patient 2 was 44,600, with blood film showing many plast cell myelocyte and normoplast. Nucleated RBCs per 100 white BCs was 1.5 for patient 1 and 1.10 for patient 2. They had anemia with thrombocytopenia. Patient 1, her platelet count was 82, and patient 2 was 29. Corrected Ratix was elevated for both. LDH was elevated for both. However, total bilirubin and indirect bilirubin was normal. Ferritin was partially high, 515 for patient 1 and 320 for patient 2. Till now, what do you think at this stage? We are dealing with patients with leukocytosis, anemia, thrombocytopenia, hepatosplenomegaly. We thought about malignancy, acute leukemia, chronic leukemia, leukocytic adhesion defect, immunodeficiency with leukocytosis like CGD, storage disease, HLH versus infection. As I mentioned, blood film showed a leukoerythroplastic reaction with immature cells. So we started to look for the differential diagnosis of the leukoerythroplastic or leukomoid reaction, which means the presence of immature erythroid cells and myeloid precursor like metamyelocyte, myelocyte, promyelocyte, myeloblast, and blast cell in the periphery. Causes of leukomoid reaction could be solid malignancy, hematological neoplasm, hemolytic diseases versus infection. Another paper showed that most of their patients with leukomoid reaction had a positive blood culture and positive urine culture, suggesting that infection could be the cause of their leukomoid reaction. Again, we are facing two cases with either a benign condition like chronic hemolytic anemia, storage disease, infection, osteopetrosis versus malignant condition with acute leukemia, juvenile myelomonocytic leukemia, or HLH. So we did X-rays for the patient, and it was normal, excluding osteopetrosis. And for the juvenile myelomonocytic leukemia, they actually fulfilled many of the criteria. However, we did a bone marrow to investigate for blast cell in the marrow. Bone marrow in both were hypercellular, erythroid was hyperplastic, myeloid showed normal sequence of maturation with blast cell less than 1% and no abnormal cell or malignant infiltration. We thought back about looking in the details of the CBC of both patients. We found that they both had microcytic hypochromic anemia with a positive history of consanguineous parents. So we started to look in the more benign condition like chronic hemolytic anemia. We did hemoglobin electrophoresis of both patients. Their hemoglobin F ranged, one of them was 40% and the other was 60, and A2 was 1 and the other was 2.5, A1 was 37.5 and the other was 59. CBCs of both parents showed a microcytic hypochromic anemia for which hemoglobin electrophoresis was done, and it showed a beta thalassemia trait with high hemoglobin A2. So we proceeded to genetic testing for beta thalassemia for both patients. Patient 1 proved to have a homozygous mutation intervening sequence 1110, and patient 2 had a homozygous mutation for intervening sequence 11. When we reviewed the literature about the spectrum of beta globin gene mutation in Egyptian children with beta thalassemia, a paper published by Shanshuri and Al-Alfi, the results of them came that the most common mutation among patients was intervening sequence 1110, followed by 16, followed by 11, and 15. Here we have to mention that a beta globin gene is composed of 3 exons with 2 intron or intervening sequence, and that the clinical severity of the disease depends mainly on primary modifier, secondary modifier, and tertiary modifier. Primary modifier is the mutation affecting the beta globin gene. Intervening sequence 1110 usually cause a clinical phenotype of beta plus. However, intervening sequence 11 usually produce a beta 0 mutation. Another paper showing the association between genotype and disease complication in Egyptian patients with beta thalassemia, which was a cross-sectional study, revealed that both of their patients who showed intervening sequence 11 and 1110 have a clinical phenotype of beta thalassemia major. The current condition of both patients after proper transfusion, their total count dropped markedly, their hemoglobin elevated, and the platelet count partially improved. And as regard the clinical evaluation, their spleen size partially improved. The take-home message for these cases is that beta thalassemia major is the most common hereditary anemia in Egypt, so should always be suspected in any patient with microcytic hypochromic hemolytic anemia, and that early onset and aggressive form of beta thalassemia is present and may lead to death if not properly diagnosed and managed, and leukoerythroplastic reaction with thrombocytopenia may be the initial presentation of transfusion-dependent thalassemia. And lastly, we have to have a close view of the details of the blood picture before going to fancy investigations. Our third case is about a female patient who was 8 months old, first order of birth of non-consanguineous parent. Her mother has a long term of infertility. She had a negative family history of any hereditary disease, presented to us with gradual onset of pallor, starting from the first week of life with no jaundice, nor change in color of urine, and maternal antibody strain was negative. On examination of this child, her weight and length were below the 5th percentile. She had pallor with no jaundice, no organomegaly, nor lymphadenopathy, with multiple skin pustules on her trunk and no congenital anomaly detected. Her serial CBCs showed a mild leukopenia with neutrophil count ranging from 0.2 to 1.3. Hemoglobin is in normocytic normochromic anemia, and the platelet count borderline, although one CBC showed a normal platelet count. Her retics was low to normal retics count with normal metabolic profile. To summarize, we have a female patient with borderline growth curve, neonatal onset of transfusion-dependent normocytic normochromic anemia, neutropenia, normal to low retics. So we suspected either immunodeficiency versus bone marrow failure syndrome. We proceeded to bone marrow aspirate, which showed a hypercellular marrow with a granulocytopoiesis showing a maturation arrest with hyposegmentation and hypogranulation, and the majority of the granulocytic precursor showed heavy cytoplasmic vacuolation. Erythropoiesis showed a dysplastic features. Iron stain was increased with 85% ringed sideroblast, megakaryocyte were dysplastic with many dwarf megakaryocytes are seen. Their conclusion that it is a marrow of a multilineage dysplasia. Terrifying also showed the same results, hypercellular with average cellularity 100% and many dysplastic features. So we started to look about the classification of syndromes and conditions that may predispose children to the development of myelodysplasia. First of all,
you have 1 minute.
Inherited bone marrow failure syndrome, germline mutation. There was case report about pediatric myelodysplastic syndrome with cytoplasmic vacuolation, as it is not common in myeloid precursor in myelodysplasia. So we have a child with dysplastic bone marrow, vacuolated granulocytic precursor, neonatal onset, inherited bone marrow failure syndrome with neonatal onset like Schwarzman-Diamond, Minke, mitochondrial disorder was suspected. Mitochondrial panel showed a genetic diagnosis of mitochondrial DNA deletion syndrome, Pearson syndrome. This is a review of literature showing about the hematological presentation of children with Pearson disease, normocytic to macrocytic transfusion-dependent anemia found in all patients. Vacuoles in erythrocyte and myeloid precursor are observed in all patients. Our take-home message is that anemia is generally the only presenting manifestation of Pearson disease. Other clinical signs like ring sideroblast and pancreatic insufficiency are often missing. Bone marrow morphology can resemble myelodysplastic syndrome. However, recognition of the vacuolated myeloid and erythroid precursor lead to the correct diagnosis of Pearson disease in all cases. I want to thank my dear professor في وحدتنا. I'm honored to be in such a wonderful unit. Thank you, dear Professor Iman Rajab, our mentor, for everything you are doing for us. Thank you, my colleagues and our residents. Thank you, Doctor.
Thanks a lot, Dr. Nihal. A great presentation. I think we will discuss this presentation and these three cases after the next speaker, Professor Antonio Piga. We are keeping the elegant speaker to be the last speaker. Thank you very much.
Thank you.
Yes,
I apologize. Yes. Okay. So I apologize because I have an unstable connection to the internet. I had to move. And so I hope that you may hear me and see my slides. So I do present a very simple case in comparison with the previous one, but I guess that may have some utility for young doctors. A child with a raised serum ferritin level. You see an Italian boy at the age of 3 comes to the attention of the pediatrician because of lack of appetite. Born premature with respiratory distress disease, at physical examination, nothing strange. He had general blood test, normal, with the exception of serum ferritin, that was 600 at that time. The finding was not considered relevant. And then after 3 years, at the age of 6, for the advice from a second pediatrician, iron markers tested again. So serum ferritin more than 1000, serum iron, serum transferrin, and transferrin saturation normal. Then after 6 months, again, new test looking just at ferritin with this value. Serum transferrin and iron repeatedly normal, and no anemia. The blood test was fully normal, and normal physical and cognitive development. So nothing strange with the exception of ferritin. So he had a further investigation with liver function test, thyroid function, abdominal ultrasound, everything fully normal. He had testing for genetic hemochromatosis, HFE gene showed an heterozygosis for H63D mutation, with the mother negative and the father with double heterozygosis for the same mutation, obviously, and the C2A2 guy. At this point, the family is referred to our center for further evaluation. What we did, we simply confirm in the father the genetic testing, and then we went to assess the phenotype to look for iron overload, looking for liver iron concentration. That showed a moderate iron overload, whereas there was no sign of fibrosis testing non-invasively by FibroScan. And so in the child, again, our blood tests were normal, with serum ferritin raised, no iron overload, so liver iron concentration till normal, and no liver fibrosis. That is the point. So what to do? Clinical reasoning. We started to reasoning because this is the case that is restricting the differential diagnosis to what? Nothing acquired, because everything was, let's say, constant for many years, for the life of this subject. So go to the genetic form of hyperferritinemia without iron overload. And so using any of the many flow charts that are published and running, there are several. I did select this one because it's not ideal. It's because it's for adult subject, but is good because it simplifies the clinical reasoning without going to too many details. So how to run the clinical reasoning? At first, to look for transfer in saturation. Transfer in saturation is normal or not. And if transfer in saturation is high, look for anemia. If there is anemia, obviously we go to search for iron overload, and we consider many conditions with anemia and ineffective erythropoiesis, including thalassemia, obviously, and including also a long list. Here there are the two main genetic conditions, all of them rare, that give hyperferritinemia, but with transfer in saturation high and with anemia. If anemia is not present, but transfer in saturation is high, this is a chapter that is relatively common or very common in the adult medicine. We see a lot of adult patients and elderly patients with this condition because we have to rule out conditions that may be relatively common today, like inflammation, alcohol, and liver problems, including the metabolic syndrome that is more and more common, and also cancer, obviously. And it's easy to go to the main gene for genetic hemochromatosis, HIV, and test it and see if there is something or not. But this is not the case. Our child has hyperferritinemia with normal transfer and saturation. So directly, why not to go? And if anemia is not present again, so we should, in case of anemia, we should go and consider condition with no iron overload. We should go and consider condition of anemia of chronic disease, anemia of a chronic or an important condition of acute inflammation, or a rare condition like a ceruloplasminemia, Gaucher disease. But our case is with no anemia, so and no siderosis. In case of siderosis, again, Gaucher and obviously other diseases that deals with genetic hemochromatosis. But our case take us simply to condition of hyperferritinemia that are genetic, with or without cataract, and this is the case. So that is very simple as any disease. When in medicine you know, you met, you studied, you considered something very easy. When you don't, it's very difficult. So what is this syndrome? It's the position of the excess of ferritin molecules, L-ferritin molecules, in the anterior chamber of the eye. And this is if the aspect is this star-shaped in the central part of the chamber, this is close to pathognomonic for this genetic condition. But is very rare to find the full feature of this. Normally there may be many different aspects, but it's the lesions are ever central, in the central part of the chamber. And going on with the age, as in this case that went to surgery to remove these opacity that were causing the cataract condition, a clinical cataract condition, you remove masses made of ferritin molecules that are degrade. So that is the diagnosis. And what to do, or what the many pediatricians that saw this case during 6 years of life could have done very simply, as ever in medicine, history. And family history in this case and for genetics is key. And also in this case was obviously positive since many years. So you see the mother and 4 other maternal relatives had high serum ferritin, and a couple of them had the right diagnosis done from the genetic point of view, and 2 of them need surgical intervention for cataract, and not the mother having a coexisting severe retinopathy. That was history was clear since the beginning. And obviously, we did the molecular investigation, and we look and we find this mutation A37C. You may forget, obviously, the mutation, but this is useful to go to see the clinical consequences. So what is this? Just a reminder of what we are talking about. We know that let's say the main iron proteins do have a very potent and sophisticated regulation to have a certain effect in condition of high iron and the opposite in condition of low iron. So for high iron, the main responsible for regulation is this so-called iron regulatory protein that in case of iron regulation is closed. So it doesn't bind to the IRE, that is the iron regulator elements that is on the mRNA of ferritin, in example, but on the 5' extreme. So in this condition, the mRNA translation proceeds, and so we have a lot of ferritin. And this is very good to have, obviously, a lot of ferritin in the cell to store as much as possible of iron in excess. When we do have low iron, the opposite. The IRP is open, and so it matches this loop, and mRNA translation is blocked. This is for ferritin. For transferrin, is exactly the opposite. Transferrin do have several, not one, but several IREs at the 3', and so the effect is exactly the opposite. That is fully functional to have a lot of transferrin when the iron is low, and the opposite when the iron is high. That is the story. So our patient has this mutation at this point, 37G, and that is here on the loop of this element. And many mutation has been described in the medical literature, and the effect is different because the more is the mutation apical in the apex of the loop, more effect, more consequences, more effect, and so the higher is the serum ferritin level. Our child had this level that was on the average of what is described in this. That is the story. So what to do and what happened? The follow-up of our child, very simple, because he didn't show at that moment any visual deficit. So the ophthalmologist was very happy, but is continuing the follow-up. It's now has some sign of, but not clinical, so no need of surgery, obviously. And that is for the patient. For
Professor Antonio.
Yeah, I finish just to say in the take-home messages that even so simple, high serum ferritin must be explored, because some patients do have a misdiagnosis of genetic hemochromatosis and erroneous treatment like venesection and other things. So it's very important to have in mind. Very simple to learn once and not forget for the medical life. Thank you.
Thanks a lot, Professor Piga. It was a very good presentation, and it's very important point to take care about it. I think we have time for discussion of the cases, and by the audience and by our chairpersons. The first, are you Dr. Masan? Yes.
I have only a suggestion. We have like
yes.
21 minutes, and we have 5 speakers. So we give one question either from the floor or from the chairs for each speaker. Then we ask you that if we are allowed to ask Piga in one case and Charlotte in one case in quickly before we close the session. So go ahead. Thank you.
Okay, so it's one question for every speaker. I do not want to start by myself, but I was the first speaker. I presented a differential diagnosis of, or 2 cases of early presentation with hepatosplenomegaly, thrombocytopenia, and anemia with the delayed diagnosis. If there are any questions or any suggestions also.
We'll start with Professor Piga. If you have any comment, Professor Charlotte, then the floor.
Yes.
Sorry, which case? Can you repeat which case?
Yes, Professor Charlotte, you made the comment on the GMML case about the importance to look at the immature cells in the peripheral blood. You have other comments on these cases?
No, thanks.
Thank
No,
you,
thanks.
thank you,
Yes.
thanks a lot.
Very good
Thanks.
presentation.
Yes, the second presentation is the presentation of Professor Ahmed Megahed about the patient with eosinophilia who had focal lesions in the liver, and they proved to be bilharzial focal eosinophilic hepatic necrosis. Any question from the panel or from the audience?
Which is actually very rare. Schistosomiasis disappeared from Egypt since like 2-3 decades and replaced by Hep C. And now with the presidential campaign, we are getting rid of Hep C. So I hope this is not that schistosomiasis is coming back after we get rid of HCV.
Yes, it's an alarming case, Professor Mahsen, because we thought we got rid of the bilharziasis. So it's really alarming.
Yes,
okay.
It is rare and the incidence is dropping. Actually, it was like almost something around 15% and almost in the 50s and 60s, and it is now dropping to just less than 1 in Takahliya governorate. The last estimate is about 1.3%. Though it is rare, it is still present, and the presentation by a focal lesion and acute presentation like Katayama fever, for example, is a very rare, and this is perhaps there is no previous reports of a bilharziasis presenting with focal lesions in pediatrics. The demonstration that I had presented are adult findings. This is perhaps the first report of bilharziasis presenting with focal lesions.
May I ask something about this case? Is it, since you are telling us that this is very rare, could it be something related to immunology of such a patient, or it can happen elsewhere or anywhere? And if there are some sanctuary sites or governorates we have to follow because of the coming back schistosomiasis in such case, you believe that there is something behind the immunity in this patient, or it can happen in any patient? If there is anything behind?
I do not believe that there is something in particular behind. He was not immune suppressed or something like that. But you cannot fully understood the homing of eosinophils. For example, a person with atopy, he may have allergic rhinitis, he may have bronchial asthma, he may have skin disease. This homing is related to the genetic backup of the patient and to the cytokine profile and the cellular signaling, but there is nothing wrong with that patient. And in that patient, during the acute phase of schistosomiasis, the eosinophils homed to the liver and produce this focal eosinophilic necrosis. So, it might be something related to his genetic backup rather than a definite immune disorder.
I have a question. Oh, sorry. Sorry, go on.
Yes, Professor Piga.
I have a question on teaching to medical students. That is, if this type of problems fell down in your country, but these topics are still present in the medical
curriculum? No. In the poliomyelitis, diphtheria, schistosomiasis are actually not now in the curriculum, at least in pediatrics.
I see. Okay.
But it should be kept. We should never forget.
The situation differs from Cairo to Mansoura because our referrers are almost off rural areas.
And you have to follow the sanctuary sites where it resides still.
We are still seeing some cases. It is rare. Yes, of course, it is rare. But we still see some cases with intestinal bilharziasis, some cases with periportal fibrosis and portal hypertension secondary to bilharziasis. This is because we are a tertiary referral center and we are hepatologists. So we are still picking some cases.
But I think in such case, you have to follow for malignancy. In this case, you have to follow for malignancy, hepatic malignancy. Later on, in this case, you have to follow the patient.
Bilharziasis is less likely to by itself to produce cirrhosis. It is not a cirrhotic disease. So the incidence and the extent of fibrosis is not that massive.
Okay. So yes. الصوت بيقطع شوية دكتور أحمد.
We move to the second case, Dr. Azza, Dr. Islam.
Yes. The third presentation was by Dr. Islam Al-Hawari. Her patient with hepatosplenomegaly, lymphadenopathy, and who had hypoechoic splenic lesions, and by pathology non-caseating granulomas in the lymph nodes. Okay, where she put the possibility of TB not responding to antituberculous therapy. So there is a possibility of sarcoidosis by exclusion. So what's the panel opinion in this patient?
Well, I don't have a panel opinion.
Actually, I am the one who told the doctor to think about sarcoidosis. Yes. Yes, Professor Charlotte.
My question.
I would say I don't have a panel opinion. I share the opinion that you're missing.
I really have a question for the panel, if I can.
So you think it could be sarcoidosis, or we missed something?
Well, I think you missed something. I'm not sure what you missed, but the one thing is, and that's what I would do, carefully look again at all the investigations for Mycobacterium. And I think this would be top on my list.
Mycobacterium.
Yeah, and I think, I'm not sure, but I would go back and look at the PCRs which were done and all the different tests for Mycobacterium, because I think it must be more common than sarcoidosis.
They were repeated twice. All the investigations for Mycobacterium tuberculosis were repeated twice, including the PCR. The PCR, the Zell-Nelson stain, the interferon, the quantiferon, and
when you do the PCR, Islam, he was already on anti-tuberculous treatment.
No, before it. Before it.
Okay.
Yeah.
Antonio, do you have any comment for such case?
But I am more convinced by the lack of response to treatment, switching to sarcoidosis, because this is not, it's ever possible, sure, but it's uncommon. If the treatment, you said 3 drugs done well, the treatment has been done well, so it's.
Yeah, he received rifampicin, pyrazinamide, and the INH, and they all were given initially on daily basis. Then in the last week, they switched into alternate day therapy. Yeah.
May I give a comment about this
pathology
results?
This doesn't include tuberculosis, but is
Professor Iman.
Strong factor, yes.
Yeah.
Many of
Professor Iman?
Yes, many of the immune dysregulatory disorder, immunodeficiency, in the biopsy result, you do not find simply lymphoproliferation. They may be sarcoid, non-caseating sarcoid, similar to sarcoidosis. That's why I guess the exome sequencing to our target sequence to the immune dysregulatory disorder would be beneficial while investigating this child.
How do you think, Charlotte, for this?
Okay.
I think could be a good opinion, yeah.
Antonio?
Yeah, the same, yeah.
Yes.
Next case, Azza?
Good, thank you.
Go for the next
case. So let's move to the 4th presentation. Yes, it's Dr. Nihal Hussein. She presented 3 patients with anemia, refractory anemia. 2 of them showing leukoerythroblastic reaction in the peripheral blood, and they proved later to be beta thalassemia. And their peripheral blood picture and even the thrombocytopenia, they improved after they went on regular transfusion therapy. And another patient with refractory anemia, neutropenia, skin lesions, whose bone marrow showed multi-lineage dysplasia, vacuolated granulocytic precursors, and he proved to be Pearson syndrome. Okay, let's discuss them one by one, if you are interested.
Professor Charlotte.
Professor Charlotte.
I think the first 2 cases are interesting, somehow straightforward, because you have to think of that because of the microcytic anemia. For the 3rd case, I was wondering what the skin lesions were, because that was a typical case of Pearson syndrome, and the skin lesion may be explained by neutropenia and infection. They're not part of the syndrome. So my question is, what are the skin lesions in this child?
As regard the skin lesion, we also thought about the neutropenia. Yes, about the skin lesion, we also thought about the neutropenia as a cause of skin infections, as they were infection. The patient was associated with fever and improved on antibiotic intake.
Yeah, I think I would agree, because there must be secondary to neutropenia, otherwise you can't explain them. And the one thing I couldn't remember in the end of the presentation is children with Pearson syndrome usually are macrocytic when they present. Was there macrocytosis in this kid?
The MCV ranged from 88. The lowest MCV it showed was about 79. However, the highest MCV was 88.
Okay, it's not very macrocytic, but you will see it probably goes up during the clinical course. I think a very interesting case, unfortunately a very sad case if you look at the prognosis of this child.
Yes, yes.
Professor
For the first 2 cases I appreciated because are not fully typical, so good for learning. In any case, a question is who has been the first to consider thalassemia? Has been you, or there has been this suspect diagnosis at the onset?
No, it was Professor Iman Ragab initial differential diagnosis of being beta thalassemia.
It was missed for how long, Nihal?
Sorry, doctor?
It was missed, the diagnosis for how long?
No. She was not missed at all. Yani she was presented to us on December 2020, and then she was diagnosed very rapidly. But she was before coming to us, she was transfused once or twice outside our hospital without reaching a definite diagnosis.
Do you want to have comment, Iman, before Antonio, then Antonio?
Yes, because of the thrombocytopenia, and we have 5 kids, the same scenario. Because of the thrombocytopenia, she was referred to an oncology center apart from ours, and one of them were actually pursued for the genetic analysis for the GMML, and she was then referred to us. That's why we thought to present it, because when we find thrombocytopenia and anemia, even with microcytosis, sometimes thalassemia, which is very basic, can be missed. That's why we thought to present them.
It is described, Iman, thalassemia with thrombocytopenia, either X-linked or autosomal recessive, in many publications. Antonio.
Yeah. No, my question very easy is this: that is, at which level is today, roughly speaking, in the Egyptian pediatrician, the awareness about thalassemia? Just to have an idea.
Most of them.
Yeah, but not obviously this audience today, but in general, I say in general.
Yeah, in general, the last year, Charlotte put a stress point, which I stress it all the time. If you have microcytosis, you look for iron deficiency anemia, thalassemia, minor, sideroblastic. So the simple is the most important. I am very upset when a case of hemoglobin, like I presented, of 5 or 6, and MCV of 50, then they go and do G6PD assessment with no hemolysis. So the point is the priorities a little bit is not clear in the mind of the GPs. That's why we do such workshops and such meetings, try to make awareness more.
Sure, but don't be upset. Don't be upset. Continue to share and disseminate. That is good.
Okay. Last, Antonio case, Azza, if you'd like to raise the questions for Antonio case.
Yes, I will make one comment, because we are working Gaucher disease. We do see hyperferritinemia in patients with Gaucher disease, and we were very much annoyed about the high ferritin level. And even in some of them who were on treatment for more than 10 years or something like that, we did an MRI for the assessment of the liver iron content, and we were astonished that in spite of their hyperferritinemia, there was the liver iron content and the hard iron content were normal. We did not find hemosiderosis in any of them. We did screen about 10 or 12 patients for that. We do see the ferritin, the very high ferritin.
There is some evidence, so it's not evidence, but it's a couple of papers that try to understand this, and it seems that this serum ferritin so high in this type of condition is by hypersecretion by macrophages, and not obviously by leakage, cell leakage, that is not the case, generally speaking, in Gaucher. So you are right, it is very important, your point.
Yes, it goes with the other biomarkers of activity.
If you allow me, Azza.
Thank you.
You remember Professor Charlotte last year, we present a child, 9-10 years, Ritaj Dashuri, and she has macrothrombocytopenia and non-hemolytic anemia, and the IQ is borderline, and we send you the samples, the bone marrow, and you send the report. This was like 7-8 months, and I promise I will not ask, because it will go for the research, but I ask because the family are a little bit worried, and maybe they are sharing the case with us. So I sent you an email yesterday, if you have chance to look for in the lab, in the genetic lab, if they do anything or not.
Well, this is out of the thing. We did send a report, and we didn't find any genetic lesion in that kid.
Okay.
Yeah.
Okay. No. The genetic screening was not sent, only the bone marrow examination, and you said it will go to the panel at the time it will come. You check it, and if you find anything, it will be good.
I send it back to you. Yeah.
Okay. Okay.
Professor Piga, just a question. Sorry,
sorry,
just
sorry,
a
Dr.
question
Galina.
about the land.
Dr. Galina, please.
Yes.
Antonio, I discussed with you the case of thalassemia who developed nephrotic syndrome. And our nephrologist is with us. Up till now, he didn't do renal biopsy. Now the story, as you remember, is 7 years old. His hemoglobin after starting steroids over the last 4 or 5 months is high, is 13 for 3 months before is transfused again. LIC is only done yesterday, it was 1.5 milligram, but the serum ferritin is 1700, 1200. So serum ferritin, the point, we should never rely on it. We push more chelation, and LIC is 1.5. So he is receiving full dose of Ferribrox, 100, but of course I'll make it 75 before I know the LIC. So I want to raise the point with Professor Ihab Al-Hakim, who is among the panelists now.
My general comment is that I would be knowing very well the drug, that is the chelator, the Feraziroc, that is a very good drug, but very potent, and to be handled with care when the iron overload is not high. In general, I would suggest not to go up with the dose in general, and in this case, obviously, considering this case. And then the very interesting point of your case is that it seems from the clinical setting, it seems a pure nephrosis with no component of glomerulonephritis at the moment. No, that is strange if we reasons only on a toxic effect from a drug, that is from that drug. So that is strange. So you should consider also to have a random association of a nephrosis in a child. I guess that the family history for renal diseases is negative for the child in the family. Yes, okay. And a random association of thalassemia treatment and nephrosis. But I would recommend strongly the biopsy because it's invasive, but in good hands is not so invasive. One, the risk is very low. And second, may give important information on the diagnosis and more importantly, what to do in the follow-up now.
Professor Ihab.
Yes, thank you for giving me this opportunity to join this panel. And I'd like to say that the patient, from the point of view nephrology, is steroid responsive. He's in the age of the minimal change nephrotic syndrome, and with no renal impairment, with no hematuria. And for us, there is no indication for a renal biopsy. And if you are insisting to do a renal biopsy, I'd like to ask what kind of specific finding you are searching for. Or would it better to do a genetic study? We might get a relationship between both.
No, I am ever on the side of the patient. So if there is no indication, no biopsy, and I'm happy with the patient that is happy and the parents. But here the point is that there is a disease that must be controlled forever and requiring treatment and with a high risk of kidney disease on long term. And is taking a drug that is very important from this point of view. That is the point. So my question is, are we missing something? But if my nephrologist say no, I relax. So
but he's partially responding. Ihab, Antonio. So with the steroids, like full dose steroid for 6 weeks, his proteinuria comes down from 2 grams to 1 gram, then we are tapering the steroids for fear of steroids. So he is partially responding, not fully responding. Professor Ehab.
Yes, but this is considered good for as a response for such patient, and we are tapering the steroid very slowly. And I would like to seize this opportunity to ask if the steroids might have a role in the control of thalassemia, because his blood transfusion frequency has decreased significantly with the start of full dose steroid. Do you think this might have a role?
We don't know. This is the right answer. There is no evidence on steroids and erythropoiesis, but there are a lot of observation, that are good for speculate and make hypotheses, not to conclude, that say that generally speaking, in a condition like thalassemia, you give steroids, you have some positive effect on the erythropoiesis. Then in some cases, you may have a strong effect, but a few. In general, you have a small effect. And it's not strange. And we could discuss why there is this, but I don't want to bore you too much. But expected, as probability expected, how large has been this effect?
I think Professor Alfie knows that he's have been for about 6 weeks without any blood transfusion, or even more. Yes,
3 months.
The same,
3 months.
The same pre-transfusion hemoglobin, not changing that.
Yeah.
No. Now, so he keeps 13 grams in 3 months' time. Yeah. But so it is completely different. He was transfused before every 4 weeks, now every 12 weeks. Professor Galila, if you have question, please.
But I'd like to raise this point, because if there is an indication for the steroids in this patient other than the nephrosis, we might agree together to taper the steroid more slowly if it's beneficial and it has no side effect.
No side effect on long term from steroids.
No one could dare to say so, even Antonio.
Yes, I'm joking.
Yeah.
But you know better than me that if the effect is important and relevant in changing the condition and treating a patient, yes, but to have an effect in a genetic disease that will require transfusion to go on with long-term steroids, I do not recommend.
Do you think that in this patient, it might be beneficial to do a genetic study, maybe a whole exome sequence, who might get a defect that causes both together? Although it's not that common. I haven't seen it before.
Sorry, I didn't grab. Searching for what?
A genetic defect that joins the two conditions. Might be something new.
Yes, from this point of view, a biopsy may give you surprises. No, that is, but you are right. That is, if there is no indication, but to speculate on these, you should have more in your hands. So, in what seems to be useful, but again, there is no evidence. So there has been some paper going in depth on this. That is, if you look at the change in gene expression before, during, and after deferasirox, the drug, you find a lot of things. Difficult to be interpreted. That is the story with gene expression. But in this case, maybe that discussing with an expert of this may be useful, and setting what to do in case you change treatment and or in the follow-up.
Professor Galila, last comment and last question.
But I have another question, please. If I'm going to need another drug, another immune suppressive other than the steroids, do you recommend or disrecommend the use of mycophenolate mofetil, for example, or cyclosporin A?
I'm not so expert to tell you in details. In general, again, the point is for how long? If the hypothesis is to treat for, let's say, weeks or a few months and then to stop, keeping the point, yes. But if the point is, okay, treat to keep the level of renal damage at a lower level forever or for many years, I do not suggest.
Okay, Professor Galina.
Yeah, this is for you, Professor Piga, about this hyperferritinemia. Since you don't find any change in the liver or in the heart or whatever as hemosiderosis, but later on he will develop the cataract. Do you suggest by any means to give the chelator to avoid this, or this is inevitable and you cannot prevent it by the chelators? And at what time?
No,
Yes.
no, there is no indication to, sorry. There is no indication to iron chelation in this condition, hyperferritinemia, because you have a subject that genetically have lost partially or totally the control of ferritin synthesis. Ferritin synthesis, that is the protein to grab the iron. But the iron, there is no iron overload. So what happened? That is an excess of ferritin synthesis is giving this clinical condition with the only known damage at the level of anterior chamber of the eye, nothing else. There are studies on this and nothing has been. And also, many patients with this condition do not need surgery for cataracts because it's typical to rise up during the pediatric age and then with adolescents to have a lowering of the impairment. So they do not progress, a part of patients do not progress severely. And there is no iron in excess. So the risk using iron chelators is to give toxicity without obtaining nothing on the serum ferritin synthesis.
Thank you.
Thank you. Before I leave the floor for Professor Azza to close the session, I'll make the announcement that the panelists will meet at 6 p.m. It will be a two hemophilia successive session, the Iron Woman and Man, and the two symposia, CSL and Takeda. And for the attendees, we'll join 6:15. And I leave the floor for Professor Azza to close such wonderful Harry Potter session.
Thank you very much. I hope next year we will meet in Cairo, live face to face, and there will be no corona, no more. Yes, thank you. Thank you, eminent chairpersons, Professor Antonio Piga, Professor Charlotte Niemeyer, and thank you for the coordinators, and thank you for the eminent speakers. And I hope all our discussion will be always in the benefit of the patients. And thank you for Dr. Khadiga for managing the internet connection and these things very successfully. Thank you for you. Session is closed. Thank you.
Charlotte, remember when you make the rehearsal with Antonio and you said in 2 days the Oxford AstraZeneca will be back it is already since yesterday the EU accepts the AstraZeneca for COVID vaccination again. Your expectation, it takes only 24 hours to happen. I thank Charlotte, Antonio, and Tantawi, and all the panelists and speakers, and of course Khadiga and Muhammad Gafi for wonderful time. Both of you, Charlotte is invited definitely 2022, and Piga, if you are would like to see the large museum, the King Tut is there, and you know they move more than 20 times what was in Tahrir Square, so it will be really huge and really attractive to visit the new huge museum by the pyramids.
Well, thanks a lot, but we don't want to go into the water.
Thank you, Antonio. Thank you, Azza. Thank you, Charlotte.
Bye-bye.
Okay.
Bye-bye.
Bye. Thank you.
Bye.
Bye.
Closing the session.